Hello, and thank you for joining us to learn more about models that shape better care. I'm Dr. Stuart Goldberg, Chief, Division of Leukemia at the John Theurer Cancer Center of Hackensack University Medical Center. And today I'm speaking to you on behalf of the Association of Community Cancer Centers to talk about the role of monitoring in chronic myeloid leukemia. The key to success is recognizing that the medications are working, and more importantly, recognizing when they're not working. For those patients who are treated, we want to follow some type of guideline to follow them as they're going through their therapy to make sure that they are responding. So when we start a patient, we want to first stage them accurately. So all of my patients get a bone marrow at diagnosis. I want to make sure that they're really in chronic phase because the treatment is different for accelerated phase or blast crisis. I want to make sure that they really have CML, that the failed chromosome is there, and that there aren't additional cytogenetic abnormalities that I need to follow. I then place them on one of the Tyrosine Kinase Inhibitors, and within 3 months, I want to see the blood counts normalize. By 6 months, I want to see the cytogenetics start to improve. Now, how we watch at 6 months is dealer's choice. Some doctors will do a bone marrow at 6 months to see the cytogenetics go down. Some will do a FISH study, a simple test from the blood, and others will follow PCR monitoring at the 6-month mark to see the cytogenetics are improving. Whatever your choice, whatever guideline you like is fine, as long as we see cytogenetic improvement. But at 1 year, we want to confirm that the patient has truly had a cytogenetic response. Again, depending on your level of comfort and your guidelines, you may look at 35% or less at 1 year, or fully 100% all clean at 1 year as being your gold standard. For those patients who do not have 0 out of 20 on a Philadelphia chromosome prep by bone marrow at 1 year, we definitely need to see it by 18 months. But once a patient achieves a complete cytogenetic response, we don't need to repeat the bone marrows that often. In fact, we can now move to blood monitoring utilizing PCR technology. The PCR technology is able to determine one bad cell hiding among 10,000. And so we can follow the patients every 3 months once they have achieved the complete bone marrow cytogenetic response using this blood test. And we can watch the PCR values which monitor the Philadelphia chromosome fusion proteins, the so-called BCR-ABL fusion protein, on a 3-month basis and watch it continue to fall to very, very low levels. Now, how low do we need to go? That's still a clinical question, and still something we're looking at in the research laboratories. But most of us will look at log reductions. What's a log reduction? Well, when a patient comes in the beginning, if we take an average patient, they have, by international standards, 100%. And when they hit 2 logs down, 1/100th of what they were at the beginning, that typically would be where the marrow would clear. Our goal is to get 3 logs down, 1/1000th of a normal patient. Because when they're 3 logs down, the so-called MMR, major molecular response, it's very rare that a patient will ever relapse. So we continue to follow the patients as their PCR values fall. And once they hit that 3 log reduction, the MMR, we can then start to spread out our visits a little bit, from every 3 months to every 6 months, watching the patient cautiously and reminding them to take their medications. If we start to see the PCR values start to rise, we bring them back in and repeat the test, because the test can be sometimes an error. But if the test is really rising and we see the PCR is rising, we may want to bring them back in and repeat a bone marrow to make sure they have not lost the cytogenetic response, which correlates with long-term survival. We also may want to do a gene mutation study to try to figure out why they're losing their response and help us pick which medication may be the next choice. For example, there is a specific mutation called T315I in which none of the 3 commercially available drugs work. And therefore, these patients, we may want to switch to a completely different therapy, experimental treatments, or transplantation. But fortunately, most patients will do quite well with the tyrosine kinase inhibitors, and with careful monitoring, we can catch patients before they show evidence of disease progression so that we can offer them alternative therapies if needed. We also don't want to do our test too often because that may raise costs and anxiety. So follow a guideline, put it in the chart, follow your patients, and remind them to take their medications. I hope that I've helped to answer some of your questions about the appropriate use of PCR testing, The ACCC Resource Center can help you answer other questions that you may have about treating patients and following patients with CML in the community setting. And thank you again for taking a moment to learn more about models that shape better care.